Tona model is one of the 8 projects chosen for the Chronicity Prevention and Care Programme of the Ministry of Health and the Ministry of Social Welfare and Family, aimed at implementing a collaborative model that creates the ideal conditions for providing comprehensive care to the public through the interaction of social and healthcare services, as well as other agents from the community. The aim of this project is to provide a response to the strategic lines set out by the Government of Catalonia in the Ministry of Health's Health Plan for Catalonia 2011 to 2015 and the Ministry of Social Welfare and Family Strategic Plan for Social Services 2010 to 2013. Begun in 2012 and promoted by the Department of Social Services of Tona Town Council and the La Plana Municipal Association, with the collaboration of Tona's primary healthcare services, it defined the operating and functional guidelines for cooperation in terms of social welfare and healthcare that would lead to better for all individuals, but especially those in difficult situations. Based on a strategic analysis of the present conditions, the needs of the public and the characteristics of the local and regional social and healthcare services, a functional plan was drawn up. In the implementation stage, this has been periodically evaluated and reorganized, applying the changes necessary to ensure the model's continuous improvement. In order to achieve our goals, we have counted on the involvement of the basic social services of Tona and the region, primary healthcare, specialized healthcare, the district's 3 care homes and other agents from the community, all of whom have made a commitment to act in a coordinated and integrated way, optimizing the local and regional resources available. The main aspects of the Tona model are comprehensive, personalized and coordinated care. In order to be able to improve the quality of care, establishing common responses despite the diversity of care pathways, a local dependency committee has been created comprising professionals from social and healthcare services. This committee defines procedures, criteria, protocols and courses of action, as well as individualized plans aimed at the users of the service. Care where and when people need it, and strengthening primary healthcare in the community. The model is aimed at optimizing the potential of home healthcare services, avoiding duplicity in the evaluation, assessment and orientation of people, and making this home care the main device for covering the needs of people in complex situations. The main actions are creating conditions for greater coverage and/or intensity of home healthcare services, telecare services, and the technical support bank. Improving the safety and planning of transitions between services. Optimizing the preventive capacity of the telecare service. Comprehensive quality care for people living in care homes. The medical services of the primary healthcare centre have been incorporated into the care homes, establishing agreements with the 3 homes in the district with computerized medical record points and working with the same protocols, clinical practice guides and recommendations as the rest of the public. Promotion of autonomy and active aging. An active aging committee has been set up, which is comprised of professionals from basic social services, active aging services, primary healthcare and care home professionals who move beyond purely care home to offer their services to the community. Together, they have produced a plan for active aging activities, prevention and health promotion, placing emphasis on healthy lifestyles, physical exercise, leisure and socialization in order to also avoid the impoverishment of the relational and/or health network. Boosting training and skill building activities jointly among the professionals from the different services. The results for 2013 are as follows. There have been 6 plenary meetings on model implementation, 9 meetings of the Dependency Committee, 4 meetings of the Active Aging Committee. Identification of a potential joint population of 629 people, people in situations of fragility, dependency, complex chronic patients, or patients with advanced chronic illness, of which 36 are complex chronic patients, or those with advanced chronic illness and users of basic social services. 263 are in homes, of which 99 are in the residential sphere. 183 are provided telecare services. 19 receive home healthcare. 36 intervention plans adopted jointly. 11 pre-admittance activations of home healthcare services, 2013. 31 joint admittances of the Technical Support Service, computer access to the Dependency Management System by the Social Health Work Team. 632 participations in 28 promotional activities for health and active aging. 201 hours of promotional activities for health and active aging. Signing up of 3 collaborative agreements with the care home services of the municipal district. Reduction from 31% 2011 to 17% 2013 in the number of users who have been hospitalized during the year, going from 724 to 187 days of hospitalization. Reduction of exitus letalis in hospitals or residential nursing homes down from 54% 2011 to 25% 2013. Reduction of pharmacy costs 2008 to 2013. Fundació Can Codina 53%, Residencia Prat 11.93%. One final thought is that the professionals and resources currently existing in the community are all we have at present, and more will not become available. If we all join together, these resources are multiplied exponentially, and we, the community, all benefit together.